My name is Brian Kolosik. This is my wife, Sam. So we're from Omaha, Nebraska. We have 4 kids. Our youngest boy, so we have an 11-year-old boy, 8-year-old boy, and we have a 6-year-old boy who has Prader-Willi, and we have a 4-year-old girl. And our son Paxton just started kindergarten, doing fantastic. He was actually a patient of Dr. Van Bosse for quite a while, had pretty significant scoliosis and was casted for a while and is awesome now. I think we got the curve like right around 10 degrees. And physically, he's just doing great. Overall, he's just doing great. So I was asked to moderate this section, so I'm going to start with an introduction for Dr. Van Bosse, and I think give about an hour's worth, and then we have another presentation, and then we'll kind of save that last probably 15, 20 minutes-ish for question and answers, so at the very end of the 2-hour session here. So welcome, everybody. This is the Orthopedic Challenges and Treatment Workshop with Dr. Van Bosse and Dr. Nora Wagner. Start with an introduction with Dr. Van Bosse. He's been practicing pediatric orthopedic surgery exclusively since completing his orthopedic residency at the University of Illinois in Chicago in 1994. It's full circle, you've come back. That's great. And his fellowship at Toronto's Hospital for Sick Children in 1995. His interest in Prader-Willi developed from treating a 2-year-old child with PWS and severe scoliosis. Through that patient, Dr. Van Bosse was introduced to the community of specialists caring for children with PWS, joining them to round out the comprehensive care of these challenging and rewarding patients. Much of his efforts have been treating the very young child with PWS and spine deformities. For these children, treatment devoted to the least invasive modalities that will preserve spinal growth and chest development. These include bracing, spinal casting, and expandable implants to avoid a spinal fusion during childhood. Dr. Van Bosse is a member of the Clinical Scientific Advisory Board of IPWSO, the Clinical Advisory Board of PWSA USA, and has enjoyed giving talks on the orthopedics of PWS at PWSA USA, FPWR, FPFWANY, and PWCF meetings over the years. That's a lot of talks and a lot of acronyms. So welcome to Dr. Van Bosse.
Thank you very much. It's really a pleasure to be here, and it's really exciting to be sharing the stage with Dr. Wagner. So we have a lot of information, and we're hoping that we're going to answer a lot of questions and maybe create some more questions. What we're going to do is we'll go through our talks, and at the end of it, we'll open it up for questions after that, just to make sure we get through everything. And I got to first figure out which button I need to put. There we go. Okay. So just a quick review of Prader-Willi syndrome. It always seems helpful to just kind of go through this. Things you already know is the most common genetic obesity syndrome, first described in 1887 by Langdon Down for an adolescent girl. But it was really in 1956 that Dr. Prader, Dr. Labhart, and Dr. Willi collected a series of their patients for a paper. And then Dr. Labhart, being the middle child, got left behind. And then it was about 25 years later that the genetics of this started becoming understood, which made it very interesting. In fact, they first saw the microdeletion on chromosome 15, and then it took a long time before they figured out the idea of uniparental disomy, because there were reports in the articles about normal chromosome children with Prader-Willi syndrome, and actually that was because there were uniparental disomy. So this is on chromosome 15. It's the father's chromosome that has the issue. If it happens on the mother's chromosome, the exact same area, you get a completely different condition called Angelman syndrome. And this happens in 3 ways. You can get it through a deletion, where that little part on dad's chromosome got knocked out and it's missing. Or it can be something called uniparental disomy, where there were 2 chromosomes from mom, 1 from dad, and dad's got kicked out. So now you got 2 chromosome 15s from mom. Or something called a methylation defect, where the chromosomes all look normal, but that one site on dad's chromosome that's supposed to get switched on, the switch is broken. And so those genes don't become expressed. The methylation defect is the only one that seems to be heritable, that you can have more than one child in the family with Prader-Willi syndrome, but it is a pretty low level of prevalence that happens. So what are the things that we're going to be talking about today? Well, we're going to talk about hypotonia. This is especially what we see in the infant, but it causes developmental delays, and it also contributes to the scoliosis, to the hip dysplasia, and also to the flat-footedness that we see in a lot of these children. Why does my practitioner know about Prader-Willi syndrome? Is a question I get a lot. And Part of that is really because how rare Prader-Willi syndrome is. It's 1 in 10,000 to 1 in 30,000 births. So it's a very rare condition compared to other things that orthopedists already think are rare enough, like cerebral palsy is 3 in 1,000, spina bifida is 7 in 10,000, hip dysplasia and clubfoot, which are much more common, but still they're 1 in 1,000, 1 in 2,000 births. So Prader-Willi is several orders less common. And so that leads to kind of a generalized thinking. Well, I've got a kid with Prader-Willi in my clinic today. I don't know much about this condition, but I know about these other conditions like cerebral palsy. So I'm just going to kind of try to do the same thing as I would with them. And that leads to a lot of trouble because children with Prader-Willi syndrome follow different rules. And so the important thing is that we want to have people thinking not of, I'm treating a child who's got an issue and also something called Prader-Willi syndrome, but really I'm treating a child with Prader-Willi syndrome who has these other issues. And then we got to figure out how to make that work best. So what we're going to talk about today, developmental delays, flat-footedness, osteopenia or fragile bones, hip dysplasia, and then we'll get around to spine topics, which we'll spend the most amount of time on. So developmental delays, the children start out very hypotonic, very low-toned. And you see this even before they're born. The moms will often recognize that the babies weren't moving as much as babies in prior pregnancies. And oftentimes the babies are born post-term or by cesarean section because they just didn't have the energy to birth themselves. Excuse me, the newborn period, they can have a poor suckling ability, they can have a weak cry. And as they go on, as infants and toddlers, they have poor head control. They may have issues with sitting up initially. And the milestones can take twice as long as typical milestones. So if a typical baby is sitting at 6 months, a child with Prader-Willi syndrome can take 12 months to do that. If a typical child is walking at 12 months, a child with Prader-Willi syndrome on average is walking at 27 months. Pardon me. It's my fall allergies. They're fun. Oh, I'm okay for the moment. Thank you. So what is the treatment here? Well, it is therapy, therapy, therapy. And I am so lucky that Dr. Wagner here is going to be talking about that a little bit so that you have an expert. I can just move away from that. But bracing is also a very important part of trying to get these kids up and around. And because what you want to do is give them control of their feet and their ankles. So interesting about Prader-Willi syndrome is that they are weaker centrally than they are in their extremities. Most babies are stronger centrally and weaker in the extremities when they get that strength up. And in Prader-Willi syndrome is actually the opposite way around. But all the same, if we can give them a good stable platform to start walking on, oh, thank you, that's going to get them up sooner. So I like a solid ankle, a solid AFO. And the mantra in my clinic is I want to get them walking up any way possible and then work on points for style. I don't care if we got big clunky braces on. If that gets them standing up and that gets them more adventuresome to try to move across the room without holding onto furniture, that's a big win. And we can get them moving from there. Because once they start walking, walking becomes self-rewarding. So these are the kind of braces I like. This is for a much older child. But so they are a solid brace. Let's see if I can get my little... There we go, the mouse to work. So it's a solid brace. There is no hinge here compared to this brace that has a hinge. And I hear a lot of parents coming up to me saying, well, yeah, my treatment group said they wanted to have a hinge brace because that's what they always do. Yes, in cerebral palsy, you oftentimes will do a hinge brace so that those kids who have extra tone can get the feeling of moving their ankles. But again, Prader-Willi syndrome is a deficiency in tone. So you don't want that because they will just collapse down. You want to give them all the support that they can get. So moving on from that, let's go talk a little bit about flat-footedness. And here we're looking at a child with Prader-Willi syndrome. And what we notice when we look at him from behind is how the heel is rolled way to the outside. And if we look at the outer border of the foot, it's got a very concave curve to it. It's the front of the foot is really turned outwards. And so this is what flat-footedness is. It's that the foot's kind of sliding out from underneath the ankle there. It happens very commonly. Surveys put it at about 40% of children that have it. And it's caused by not just decreased tone in the muscles that hold up the arch, but also babies and young children with Prader-Willi syndrome tend to be hyperflexible. So they can't even rely on their own ligaments holding things in place. They have to work extra hard to kind of hold those things in place. And this causes the foot to be in a poor position for running and walking. And when that happens, with the heel rolling out to the outside, it's harder to balance. It's hard to generate a good push off. When you and I walk, we get this pushing off of our foot that helps propel us forward. Well, if your foot doesn't have a good platform and it collapses underneath you, you lose that. Your walking becomes more inefficient and you get tired quicker. Over time, the Achilles tendon can also become shorter. And you get something of a crouched position over time. Because again, if you don't have a good, stable platform to stand on, then you feel a little safer. Maybe you're a little closer to the ground. So some of these children walk with a little bit of a crouch. So poor balance, wide stance, and a wide base gait means that just because, again, they're not feeling as stable, they walk with their feet a little bit further apart. And we just add the things on here. They're delayed in cruising. Once they start cruising, they don't want to let go of furniture because, again, they want that stability. They get fatigued. And then they have something called high guard. You sometimes see this, that they walk with their hands up a little bit so that they can protect themselves if they fall. So what's the treatment for this? In my book, it is bracing. And there's a couple of different braces you can do for this. There's something called an SMO, which stands for supramalleolar orthosis. The malleoli are those little ankle bones right above your ankle there. Or a UCBL, which has a long name, which is University of California Bioengineering Laboratories. If I have a child who's in an AFO and they start to walk well, I might just take that AFO and trim it down to a UCBL. So this is what an SMO looks like. You see it comes here above the ankle over there. It usually does not come out the full length of the foot. And it's made of a softer plastic, so it can kind of accommodate a little bit. I'm not a big fan of this because typically it doesn't do a good job of controlling the forefoot. The forefoot can still slide out to the side, and I want something that pulls that forefoot over. Also, I don't think that coming above the ankle adds a whole lot to the stability of the foot, because in order to do that, you need to have some modification of how well the ankle can move, some restriction of how well the ankle can move, and that's exactly what we don't want to do at this point. So instead, what I want is a UCBL. So here's just a child with a flat foot. We're saying, well, if we put some fingers under the arch, that doesn't do the job. But if we can roll the heel underneath the ankle, that will do the job better. And that's what a UCBL does. So this is unfortunately, I forgot to put in this talk, a picture from the front of the foot, but this comes down the full length. There we go. This comes down the full length of the foot, so it pushes the foot over like that. At the same time, it rolls the heel underneath the ankle, but it doesn't come above the ankle, so they have full ankle motion. But in any event, whatever gets the heel underneath the ankle is going to help stabilize the foot a whole lot and help these children get around. All right, now let's talk a little bit about decreased bone mineral density or osteoporosis. And what bone mineral density means is essentially not enough calcium in the bone. So different studies have shown different rates of bone fragility in people with Prader-Willi syndrome. So there was a survey from PWSA USA, it's about 15 years old now, but in that, caregivers said about 9% of the time did they know that there was a diagnosis of their child having weak bones. But if you look instead at adults and you look to see who's got a fracture history, you get a different story. So there's a study out of Britain where they found that 29% of the adults had a fracture had a history of a fracture. And in fact, in that study, they made a point of saying that the decreased pain awareness that people with Prader-Willi syndrome have can oftentimes be a problem. That people will be walking on a fracture for a period of time without anybody realizing it. Another study in Philadelphia on adults showed that 45% had a fracture history. So the issue with weak bones is pretty significant. Now, there haven't been any recent studies, and I have a feeling that they probably are a lot better than the older studies because I think growth hormone has made a big improvement. But it is still interesting when I talk to colleagues of mine at this meeting, in fact, who say, oh, yeah, we still see a lot of fractures are still out there. So it still is something we need to think about. Other studies have shown that people with Prader-Willi syndrome, this is from 2004, so it's older data, but people with Prader-Willi syndrome have 20% less mineral in their bones compared to typical adults. And this is primarily in the lumbar spine, your lower back spine, the pelvis, and in the legs. Not so much in the skull, the arms, or the upper part of the spine. Although I can tell you that surgically, we still see when we operate on the spines that oftentimes the upper vertebrae are also not as strong as we'd like them to be. So what's the treatment? Well, the easiest thing is keep them on the growth hormone. There's certainly important things that the growth hormone does. What I didn't put in here is that also sex hormone replacement therapy can be beneficial. I'm not an endocrinologist. I'm not going to say who needs it and who doesn't need it, but I do know that it can help in terms of strengthening up the bones. I think routine vitamin D and calcium is an important thing. Some people do worry about getting too much vitamin D. And again, something good to talk to your endocrinologist about, but probably just about all of us in this room have low vitamin D levels. And most of the kids, even those without Prader-Willi syndrome, are also having issues with vitamin D. We find that a lot in the orthopedic community. Keeping them active as possible, because the more active they are, the more they're going to be strengthening up their bones. And having an awareness of the bone issues is important, so that if a child has what may be a minor injury, someone was just telling me about their child, I think, on a flat floor, took a fall and then started limping. And it took them a few days to figure out that there was something going on. They got an x-ray and yes, there was an ankle fracture. So just being aware that if there's any change in how they're using a body part, that there could be a fracture there. And if they need surgery that includes bone, that the surgeon is aware that the bone may be of not usual strength. I'm going to switch gears to hip dysplasia. So on the left is what a typical hip should look like. On the right is a full-grown person with Prader-Willi syndrome who has hip dysplasia on both sides. And if you compare here, what you'll see is that that red line is what we call the sore seal, or kind of the roof over the ball. And you see that on the right side there, it's not really covering over the ball. It's more kind of on the side. And that little green arrow there on the left, that space is very, very narrow, whereas on the right, it's wider because the ball is kind of slipping a little bit to the outside. It's not going to ever pop out of joint, but it's not sitting nicely inside joint. And this is what hip dysplasia is. Dysplasia essentially just means wasn't formed correctly. And that really comes from the idea that the hips are in their best shape actually very, very early on in pregnancy, because it's the hips are carved from a single block of cartilage. You get this block of cartilage and you get this little fault line that comes between the two areas of what are going to be the two areas of the joint. And then over time, they continue to mold by stress that's put across it. So because the babies with Prader-Willi syndrome are not moving much during pregnancy, they're not putting a lot of force across that area. Their own muscles are not pushing the two sides of the bone against each other hard enough to help to shape that socket. So most of them are born with a little bit of a deficit to start off with, a little bit of what we call dysplasia. And then again, they're delayed with walking, and then when they are walking, they're probably not as active as most kids. So there's all these little things that kind of compound on each other. And the big concern that we have about hip dysplasia is it can lead to arthritis. And that's why we want to make sure that we understand, because as a child, you can have a child with hip dysplasia that shows absolutely no symptoms. But then when they get more active, we know this from typically developing children, a lot of teenage or college age athletes will come to their doctors with hip pain, and you find out then they had hip dysplasia because they just have gotten now to the point that they're putting enough stress across their hips that they're having problems with it. Congenital hip dislocations do happen in Prader-Willi syndrome. I know of a few cases in my own cohort, and other centers have reported on this, but it's not the prime issue. The prime issue is really the hip dysplasia. So the incidence of hip dysplasia is thought to be someplace between 8 and 30% for children with Prader-Willi syndrome, compared to about 1% for typically developing children. So it's a pretty high percentage. And the prevention for this is really screening, getting to know if there's an issue, and then also encouraging as much activity as possible to try to get those hips to develop over time and to continue screening. Now, The issue that we talked about, the long-term problem with hip dysplasia is hip arthritis. But there aren't any reported series of people with Prader-Willi syndrome who have hip arthritis. And you say, well, maybe that's just because there's so few people with Prader-Willi syndrome out there that nobody has been able to collect such a series. But what we did is we said, well, let's take a look at a national database. So there's databases out there that collect all kinds of data for people who've been to the hospital or had surgery. And we found a database where we could look at everybody who's had a hip replacement from 2004 to 2014. And we found there were 3.1 million hip replacements. Now it says weighted there because there's a way that you can play with this to give you from the number of hospitals they looked at to across the whole US. Within that sample, there were only 39 people with Prader-Willi syndrome over those 11 years who had had a hip replacement. Now, what's interesting about that is that the majority of those who did have a hip replacement had it before 50 years of age, whereas the typical age that you and I will have will be over 55 or 60 years of age. So the people with Prader-Willi syndrome did have it earlier than typical, but if you look at those numbers, it meant that 1 out of 80,000 people with Prader-Willi syndrome, 1 out of 80,000 hip replacements was for somebody with Prader-Willi syndrome. And we already said that the incidence of Prader-Willi syndrome, even if you look at it at its most rare, is 1 in 30,000. So what that really means is that people with Prader-Willi syndrome have a 2.5 times less risk of requiring a hip replacement. So how does that jive? We say we have a high level of hip dysplasia, but a low level of arthritis leading to hip replacements. And I think it's really because of this. They have a lot of remodeling. So here's a child of 5.5 years of age, where as a pediatric orthopedist, I look at this and I go, time to do surgery. And if you see, there's that socket. That socket is not nearly covering that ball very well. Instead of being over like this, it's kind of like that. But if we look at this child, just a year and a half later, that socket's starting to come over. And here they are 3 years after that. And I would say that any pediatric orthopedist would look at this and say, these are pretty normal hips. This is unheard of in typical kids. In typical kids, if they haven't normalized their hips by 4 years of age, they're in trouble. We need to do surgery. But this is not just one case. I have several cases. Here's a child, 13 months of age. Again, we would say awful hips. We need to do something surgically about them. But here they are just a few years later where the hips have really normalized quite nicely. So with that in mind, I am a lot more observational with these hips. I do not recommend getting ultrasounds if a baby with Prader-Willi syndrome otherwise has a normal examination, meaning if they examine it and they think, oh, the hip is loose, okay, or is sloppy, meaning that you think they can go in and out of joint, okay, then go ahead and get an ultrasound. But if the hip otherwise feels like it's stable, hold off and wait until we start getting x-rays of the spine, which is when they're starting to sit, which is usually about a year or a year and a half, someplace in that area. Start looking then and trying to figure out what to do. Why is that? Don't you want information sooner rather than later? Well, the problem is if you get that make that diagnosis of hip dysplasia in an infant, then the next knee-jerk reaction is you want to put a brace on them. You want to put them in what's called a harness. And the harness it'll make them, let me see if I can act this out. They'll put them in a position where the hip is kind of up like this. It's bent up and off to the side. The problem with that is it restricts motion. And what do we want babies with Prader-Willi to do? We want them to move as much as possible. First of all, most of the babies with Prader-Willi syndrome kind of had that position anyway, because that's the position they were in intrauterally. It takes a while to get out of that position. But second of all, I want that baby moving around as much in the crib, even if it's little motions, because that's going to help them get stronger. If we put them in that harness, that's going to confine them and they're not going to move around as much. So that's my reasoning on that. All right, now we're going to get to the meat of the matter. Let's talk about spine deformities. So scoliosis, just a set of terms, scoliosis is a side-to-side curve in the spine. No, just about every spine is just about arrow straight, and so any deviation off of that is going to be a scoliosis. And then when we look at a spine from the side, up at the top, we all have a normal kyphosis. That's the curve that goes kind of to the back. And we have a normal lordosis in our lower back. That's the small of our back. but those can be exaggerated. You can have a hyperkyphosis where you have a very big curve in the upper back, and you can also have a hyperlordosis. Now, the typical scoliosis in a typically developing child is a lordoscoliosis, which means that they actually lose their kyphosis in their upper back. They become straighter, and then they get their curve, which is always an interesting thing because the parents are like, oh, my child's got better posture, and then you diagnose the curve. In Prader-Willi syndrome, they are more kyphoscoliosis, that they actually get more of a hunching over that goes along with their curve. So let's do some numbers. The prevalence of scoliosis in Prader-Willi, if we look at all the literature, is someplace between about 60 to 70%, where about a quarter of all kids with Prader-Willi will have a curve in the first 4 years. And then there's a period of kind of quietness between 4 and 8 or 10 when roundabouts the onset of adolescence. And then you get this other bump in the incidence, the development of these curves. And about 15%, and again, this number is a little squishy, but about 15% of children with scoliosis will need to have spine surgery. And I say squishy because there's not really good data out there the global registry, I think, is going to give us some wonderful data that's going to help to really make these numbers a lot more solid. But the complication rate is someplace in the literature, it's about 56%. There's apparently a paper that was just done a few weeks ago at a scoliosis meeting that said it was like 86%. So it can be a pretty high concern, a pretty high complication rate. So what is the rationale for treating scoliosis? Well, one thing to talk about is what the person's going to look like when they're an adult. If you have a curve when the child finishes growing, if the curve is 40 degrees or less, the risk of that curve progressing is only about 5%. 95% of the time, it's going to stay put where it is. If the curve is over 50 degrees, 95% of the time, the curve is going to progress. Now, this is in typical kids, Prader-Willi syndrome. The rules may be a little bit different, but this has worked pretty well with looking at my patients. And then between 40 and 50 is a gray zone. We don't know what these curves are going to do, if they're going to progress or not. We just have to watch them very carefully. In general, curves under 20, 25 degrees, we'll watch, and we start to treat them over 25 degrees. And the surgery's indicated, again, for those curves that you think are going to be over 50 degrees, someplace after skeletal maturity. And so that surgery is indicated between 40 and 50 degrees or so. Why do we need to treat scoliosis? Is it just a cosmetic issue? Well, the big problem is if you get a very big curve, you start to compromise the shape of the chest and the space for the lungs. And we talk about the fact that the lung volumes are not symmetrical. So you see this lung over here, we're looking at the patient from behind. That's how spine people look at their x-rays. So we're looking at the left lung over here, and there's a very small space over here, and the right lung, and there's a very small space here because the diaphragm is pushing up on that lung, so squishing the lung on the left. And on the right side is kind of pancaking the lung, so that we have the lung very spread out over here. And of course, the whole thing that lungs do is they're supposed to match up the oxygen that you're sucking in with the blood flow that's going through them. And when you start misshaping your lungs, those two areas don't overlap as well. And so the lungs become less and less efficient. So that's the real issue with scoliosis when you have a big curve. And if this goes on long enough, you have the heart that's trying to push the blood through these lungs that are not well made, and the heart starts getting overworked. At first, hypertrophies, at first gets bigger, and then it actually starts to fail. And that's something called cor pulmonale. Now, this typically doesn't happen until curves are at least 80 to 90 degrees, but even the smaller curves, those are 60 degrees or so. If you do respiratory type tests on, if you have them blow into a tube, you can actually see if they're starting to have some issues, although they may not themselves feel it. In Prader-Willi syndrome, we also have this interesting problem with the hidden curve. So on this child here, it's maybe a little bit of an obvious picture because he's got these little indents here that you can see on his what we call waist clefts. So you have an idea that there's something going on, but you probably wouldn't recognize the fact that he's got a 90-degree curve. He doesn't look it. Or this child here, if you really look carefully, you say, the shoulders are maybe a little unlevel. but he's already got a 30-degree curve. And so that is atypical, because usually what we do with our children is we have them bend over and we look to see if there's an asymmetry there and say, this child's got scoliosis. But there's been so many children I've seen with Prader-Willi syndrome where they said, my pediatrician was really good. They were always looking, but they never saw anything. Or they said, maybe there's something slight here. And that's because the clinical findings are really subtle on these children. And that's, we'll talk about a little bit. I'm a big advocate for just doing regular x-rays after a certain age. So there's always a question about how much does obesity play with this. And there doesn't seem to be a big difference in terms of body mass and developing a curve between those that have scoliosis and those that do not. So that doesn't seem to be an issue. More than 50% of the curves, especially in those younger children, start before obesity even happens. And it's more likely that these curves, particularly in the young children, are really due to hypotonia. It's that inability to hold themselves up well, their own muscles. And we want to control the obesity so that we can detect these curves. And certainly bracing and casting is easier if we have a slender child. There was a survey done by PWS USA that I alluded to earlier, and the data that we got from that suggested that girls have a 10% higher chance of developing scoliosis than boys. But if you have a boy with scoliosis and a girl with scoliosis, they both have the same risk for that curve progressing, for that curve getting bigger. And the same thing in terms of genetics, that it seemed that the UPDs had a higher risk of developing scoliosis, but if a child had UPD or deletion or a methylation defect, that they all had seem to have the same risk for progression. I think that's probably going to get teased out a little bit as we get more information. But right now, it seems that everybody's got about, once you develop a curve, they all seem to have about the same risk for the curve developing. But again, that the online registry, the global registry, I'm really excited to see what comes out, and I appreciate everybody who's been adding into that. So what is the treatment for scoliosis? Well, it's difficult to draw conclusions. There's few reported cases in the literature, although luckily we're seeing more and more getting reported over time. But a lot of what we're going to talk about are really my accumulated experience that has pushed my opinions here. The first thing is prevention. So most of us who've had babies, the first thing you want to do is you want to help them sit up and you want to play googly eyes with them and things like that. But the problem with kids with Prader-Willi syndrome is that when you put them into a sitting position, they don't have that ability, that central strength to hold themselves up, and so they tend to slouch. And that makes me worried that that can kickstart a scoliosis, because we have seen that in other conditions where that can happen. So what I suggest is that until a child can pull themselves up to a sitting position, that we don't put them into an independent sitting position. That we always have them leaning back in something. So in their high chair, we're leaning it back about 30 degrees or so. Anytime they're up and sitting, we're leaning them back so that they can be supported against their back. But that we work very hard in terms of other therapy. So here's a child just showing you that hypotonic slouch, that kind of collapsing down until they can't collapse any further. And oftentimes they're using their hands to hold themselves up as well. So I like to emphasize tummy time. So when the child is awake, not when they're sleeping, but when they're awake, you put them on their tummy. So they're trying to hold their head up. That helps strengthen their back. And hopefully over time, they're trying to push themselves up or reach for things, which also makes them use their back muscles a lot. Then screening. So I feel very strongly that screening should start once a child is upright and sitting. If we don't see anything, if there's no concern by looking at their back, I don't think you want to get an x-ray before they're sitting, because they can be very inaccurate when you get a lying down x-ray. But once they start sitting, I want to have routine screening sitting x-rays so that we can see what's happening with that spine. And when I say routine, if everything looks perfect, maybe every 6 months. If there's any question, if there's any concern, maybe every 3 or 4 months, just to really be on top of it. Physical therapy, regardless of what the back looks like, physical therapy is just really, really, really important. And then treatments are, we're going to talk some about casting, we're going to talk some about bracing, and then we'll get to surgery. So a quick reality check, because this always, for me, it's always heartbreaking where a family has done everything that I could ask of them, and even more so, and the curve still progresses. So some of these curves are just going to have a behavior of progressing regardless of what's done. But that's not to say that everything that's done is not for good use, because whatever you can do to slow the curve down, to delay going to surgery, that's always better for the child. Get them to grow up as much as possible before we go to surgery. So physical therapy, again, Dr. Wagner is going to talk all about this. So I'm going to move right to casting. So casting, when I got into casting these children, first of all, I thought it was an onerous thing. I thought that no parent is going to want me to be doing this. And I can tell you that I've been really pleasantly surprised by that. And the other thing is that we were only casting till about 3 years of age, because after that we had these great surgical things that we're going to talk about those in a second. But then a couple of things happened. First of all, I found from the parents that oftentimes casting wasn't as bad as I thought that they would find it, and they were happy continuing on with casting past 3 years of age. The other thing is that the surgical things that we can do, we started finding that they have kind of a defined lifespan. If we do surgery on a child to try to control their spine as they're growing, it's got a lifespan of about 5 years. So if we do it at 3 years of age, by 8 years of age, we can't adjust the spine anymore. If you get them to 5 years of age, before you do your surgery, you can get them to 10 years. And that's not a bad age to be kind of stuck with the spine. But better yet, if we get them to 7, we're going to hold off till 7 years of age, and we then grow them up to 12 years of age. That's a pretty good place to be. So, long way of saying, I have been trying to extend out my casting, and sometimes even to 7 years of age, if that's what's necessary. So, what about casting? So casting is done under anesthesia on a special table. There are a few centers that are trying to do this without anesthesia. I haven't been that brave yet. Under 2 years of age, we change the cast every 2 months. Between 2 and 3 years of age, we change the cast every 3 months. And over 3 years of age, we change the cast every 4 months. And we finish casting either when we've reached our goal, when we've made the curve small enough that we're happy, or that we kind of hit a plateau and we're trying to think of what the next step is. But bracing is always a very important part of this. So this is what a typical table looks like. And we have head halter traction. So we have something that comes underneath the chin, underneath the back of the skull there to pull traction one way. We have these little pelvic straps to help pull traction the other way. And then there's these bars that the child is resting. Whoops, hang on a second. There's a bar over here that the child's pelvis is resting on. There's another one under the shoulders. And then the bottom of the table can drop away. So we actually have access completely around the child. And this little graphic over here is showing that not only are we trying to take this curve and push it straight, but we're also trying to derotate the chest. What's interesting about scoliosis is it's not a two-dimensional process. That when you start getting a curve, if my forearms are the ribs and my fists are the vertebrae, and the child is looking down at the ground, what happens is when they start getting a curve, the spine starts to rotate, and that pushes some ribs out backwards and the other ribs forwards. And that's what you're seeing here, is that rotation, just as you're seeing in this picture here. So here's a typical child leaning over, and you see they have this prominence here. That's the prominence that the pediatricians are always looking for, that the children with Prader-Willi syndrome are not showing as much. But still, the same process holds, that as you get the rotation of the spine, some ribs get pushed backwards, the other ribs get pushed forwards. And so when we're putting on the cast, we're not just trying to push side to side, but we're also trying to derotate the chest at the same time. So this is us just putting on the cast. So we first wrap the plaster on, then we do our molding, and then we make some nice cutouts there and try to end up with a very nice cosmetic looking cast like this one here, with a big cutout for the chest and also a little cutout in the back there as an air hole. So we looked at a series of patients that we had. We had about 34 patients that we had more than 2 years of follow-up on. And our criteria for starting casting was a curve over 20 or 25 degrees, a child that was already over sitting age, because we wanted them already have that behind them, but younger than 5 years of age. So the oldest kiddo that we started casting was just a little over 5. And we found that there were 3 endpoints. There was the cured endpoint, where we put on enough cast until we got that curve under 20, between like 15 and 20 degrees. And that we call the cured curve. And that child would then go into a brace for a year and then come out of the brace. We had the braced category. These were children that we got the curve down, but we could not get it down low enough. And we figured this child would probably be in a brace for a prolonged period of time and may have surgery in the future. But again, we had gotten the curve down significantly. And then there were the controlled curves. These were ones that we probably knew from the start were probably going to need surgery because they're such a big curve to start off with. But we wanted to just allow the child to do a lot of growing before we got to surgery. And so our results were that the first cast went on anywhere from 14 months of age to 64 months of age. There were some kids only had 3 casts, some had 18 casts. And we were able to follow them for over 5 years, or for about 5 years. So about a third of the kids that we treated ended up in the cured group, which was really very heartening. The majority of those were UPD, and don't quite understand why that is yet, but we'll see how things flush out over time. And the initial curve on average was about 44 degrees, and we got it down to an average of about 17 degrees over a year and a half and 6 casts. In the braced group, there was a majority of kids with deletion. The initial curve was about 55 degrees, so these are sizably bigger curves already. We got them down to 35 degrees, so we got a significant improvement over 7 casts. But again, these are kiddos that we figure the curve over time is going to become more of an issue, but hopefully we can nurse them along until they're much older. And then we have 4 kids that were in the controlled group where we were pretty sure that they were going to need surgery from the start. The average curve they started off with was 85 degrees. We kept it at about 54 degrees to allow them to do more growing. So here's a timeline on a cured curve. Here's about a year and a half old kiddo with a 36-degree curve, which typically as a pediatric orthopedist, you look at that very, very concerned. But in the first cast lying down, we get down to 10 degrees. After 4 casts, it's a 14-degree curve out of cast. And after 5 casts, we put him into a brace. So here he is 2.5 years after we stopped casting, and that spine is still looking pretty good. The problem is that we have to keep on following these kids out to see what happens over time. Because remember, there's that second age group that we worry about when they're getting near adolescence. And that's what we see on him. Here he is at 8 years of age, looking pretty good, maybe a little bit of a return of a curve. A year later, his curve is 25 degrees. Now, he's been out of cast now for a lot of years. So it's a lot of good childhood that he's had. But at this point, we had to go back into a brace. And here he's at 11 years of age. He's got a 30-degree curve. His history is not completely written. We don't know where he's off to, but I think we significantly changed what his childhood could be like. Hold on. So it's a new technique. We have to see what happens when a lot of these cured curves get to adolescence. But here's on the other side. Here's a controlled curve. So this is an 18-month-old girl with Prader-Willi syndrome deletion type. And here's her curve. She started off with a 106-degree curve at a year and a half of age. So here she is in her first cast. And what you can see here between these 2 x-rays is you see how asymmetric her lungs look. And in this first cast, they already look a bit more symmetrical. So we've helped a lot with that. And then we allowed her to do a lot of growing. So here she is about 2.5 years later. The curves are about 60 degrees. But again, that chest looks pretty good. And we just kept working with her. 4 years of age, 13 casts. 6 years of age, 18 casts. And then finally, at that point, we said, it's time to go to surgery. And this is one of those where at 5 years of age, I said, hey, you know what? We've gone on long enough. She's a good age for surgery. And the parents are like, what's the rush? We'll go a little more with the casting. So what did we find in terms of predictive factors? Nothing that could predict which curves were going to do better than others in terms of gender, where the curve was in the spine, if it was a right-sided curve or a left-sided curve, or even what age we started casting. The biggest thing that made a difference was the size of the curve before we started. If the curve was under 50 degrees, we had a 9-time better chance of getting that curve cured compared to if it was over 50 degrees. So early recognition of the curve is really the most important part of this. And I like to say casting is survivable. So here's a 17-month-old boy with a 55-degree curve. He had 5 casts over 15 months and a brace for 12 months. And then at 4 years of age, he had a 13-degree curve and no brace. And you can always make the casting period more fun. And the girl in the middle there has actually got a dry suit on that her parents had her getting swimming lessons. So what about bracing? Well, bracing is for those kids who, first of all, are not applicable for casting because of probably age, and for curves that are over 20 or 25 degrees. Remember we said that we start treating curves when they're about 20, 25 degrees. And we want the primary thing that a brace can do is prevent progression or slow progression. It can't reverse a curve. At least that's what we typically will say. And in a typical child, that's what we think, is that it's not going to stop the curve from getting any bigger. And it can be difficult to fit kiddos that are getting to be on the heavy side. So this is what a brace looks like. And on the left, kind of hypotonic curve, you put a brace on and you get them in a better position. And this is a kind of a typical timeline. Here's a child, 32-degree curve, and this is what she looks like in her brace. And here we get her 4 years further out. The curves progress by about 12 degrees, so it's about 3 degrees per year. That's not bad, but it is still, some gradual progression. And I can't remember this child, if she underwent surgery or not. But this is the neat things that we have found on occasion. Here's a child, 5 years of age, 46-degree curve, which at that point would be a very concerning curve. Here she is in her daytime brace, and she has a separate nighttime brace. The nighttime brace kind of unbends the curve. So under 30 degrees, I like using a nighttime brace alone. If the curve gets over 30 degrees, I'll also add a daytime brace. Most treating physicians don't like that idea of having two separate braces, and it's more expensive. But you sometimes get results like this. So here she is 4 years later, and that curve is now at 21 degrees. I can't explain how that happened. It's a very uncommon thing to happen, but we have it happen here. Here's another girl, 10 years of age. Again, a 41-degree curve, which should be heading in the direction of concern. So we put her in braces, and we get her now 3 years later, and the curves are down to 25 degrees. This is completely unexpected. In the younger child, we can maybe say there's a lot of hypotonia that we're correcting, but how that worked in a 10-year-old, I don't know. And then one other example, here's a child who has kyphosis of his lower back. So this area over here, this is where he should have a small bit back, but it's actually going the opposite direction. But we put him into braces and gradually worked that out until we got that corrected. But there's no crystal ball. There are no silver bullets. So here's another 10-year-old, actually with smaller curves than we talked about with that last 10-year-old. And we put her in braces also, but she continued to progress. And so she had these very big curves and ended up needing surgery. So it can be unpredictable. So what about surgery? Surgery is indicated, again, for curves that we think are going to be over 50 degrees at maturity. And usually at 40 degrees, we start getting a little concerned. The goal of surgery is to align the spine as best as possible, not just from looking at somebody from behind, trying to get that curve nice and straight, but what seems to be much more important is the side view. You want to get what we call the sagittal profile to be as good as possible. And we hold everything in position with a rod on either side of the spine, and then different things to kind of anchor those rods to the vertebrae. There's a high complication rate in Prader-Willi syndrome, led by infections, and most of those infections happen from skin picking. So in my practice, I am very rigid about, I'm going to put a brace on this child after surgery, not to hold the back up or to protect my surgery, but to protect my incision. And that brace stays on for 3 months. And there are some anesthetic risks. So you want to have a center that is knowledgeable of patients with Prader-Willi syndrome, so they understand that. Pulmonary and respiratory issues, we're going to talk a little bit about getting a workup before surgery. Hardware issues. The typical hardware issues that we get is not the hardware. Hardware is what we call those rods and screws and everything, is not necessarily those breaking, but more those pulling out of bone. We're going to talk about that in a little bit too. And I'll make this point a few times. I always think it's very important to educate my colleagues that we treat these children as having Prader-Willi and scoliosis, not having scoliosis, another thing called Prader-Willi, because the rules are very different for Prader-Willi syndrome. And if we want to keep those complications down as much as possible, we have to be aware of those rules. So this comes out of the literature. It's a 6-year-old boy, 90-degree curve. older style of hardware, but a pretty good result. They got a pretty straight spine. But here's the issue. He's 6 years old. When he grows to be 15, 16, his chest is only going to be that of a 6-year-old because the chest can't grow anymore because they fused it. So you don't want to do that anymore. What you want to do instead is be able to grow the spine up with the child. So this is actually my first patient with Prader-Willi syndrome, also 6-year-old, over 100-degree curve. And what we put in is this is an older construct, but it is a way of having a expandable implant. So you see that there are 2 sets of rods coming from the bottom and from the top. They overlap, and so we can loosen that up in surgery and lengthen them out so we can keep up with his growth. And that meant that every 6 months we're going back to the operating room to lengthen him out. But then we got him to where he's fully grown. His curve was only about 50 degrees or so, but his lungs were much more symmetrical. And at this point in time, I did not need to go back and do a follow-up fusion because he had essentially done that himself. And so that was a way that we kind of maintain his curve. Nowadays, though, we have a much nicer thing, something called the magnetic expansion control rod, or the magic rods. This is not a promotion for them. It's just saying this really changed how most of us were able to deal with these curves in younger children. So here's a 10-year-old, an 83-degree curve, and you put these rods in, and what you see is the rod is kind of fatter in this area here, and that's because it's got a telescopic unit. And if you look at this picture here, you see there's these little clear areas inside the rod there. That's where you're starting to get this telescopic unit to lengthen out. And how do you do that? You do that with a little remote control, because in that telescopic unit, there's a little magnet sitting in there, and you put a magnet on the outside of the skin. The magnet on the outside skin rotates, and makes the magnet inside the rod rotate, and that lengthens them out. So instead of going to the operating room twice a year, you go to the clinic every 3 months, and you lengthen them out that way. Now, this has not turned out to be the panacea that we hope it would be. It's a game changer, but these rods have a lot of issues with them. And one of them is that they only generate so much power. So they can get overwhelmed and then they jam and you can't lengthen them out anymore. But all the same, this is really what most of us do as our first attempt to try to get these curves under control. And so you take this 10-year-old girl, 103-degree curve, again, older style. Sorry, moving on. This is end game. In the past, we thought that when you stretched out that spine, you got him out to length, and he had to go to the operating room, take that hardware out, and do a formal fusion. A formal fusion means between this vertebrae and that vertebrae, we're going to scrape up all the vertebrae. We're going to put bone graft next to them, put our rods, and then what the body's going to do is say, I've got a fractured bone. I'm going to heal this bone to this bone to that bone to that bone, and you end up with a fusion that way. But what we start to find with these children is as we're lengthening them out, it gets harder and harder to lengthen them out, and they were actually forming bone themselves. That's why it's getting harder to lengthen them out. That's why there's only a 5-year lifespan that we can lengthen them out. So in that case, when we get them out to length, why don't we just put in some solid rods and call it a day? And that has worked out pretty good. So we call this graduation. Now, I always say talks like these, who knows, in 10 or 20 years from now, I might be saying, boy, this is the worst decision I ever made. But up to date, it has worked pretty good. And this is so much of a smaller procedure compared to a fusion. It's oftentimes just an overnight stay. We just make a small incision at the top and the bottom, take the old hardware out, thread our new rods in underneath the skin and muscle, and clamp them back down. So what about spinal fusions? Spinal fusions are for older kids who don't have a whole lot of growth left to them, where we know the curves are going to be over 50 degrees at maturity. The timing of the surgery, we want to kind of balance how much growth we think they have left compared to the size of the curve. And what I oftentimes will try to do is nurse kids along as I can, not just for physiologic growth, meaning how tall they're going to get, but also for emotional growth. But certainly the older the kids are, it's easier for them to tolerate the emotional sides of doing this. So I will keep a child in brace as long as I can keep the curve under 50 degrees in brace, meaning at a certain point in time, I don't get x-rays out of brace anymore. I'll just get them in brace as long as I can keep it under 50 degrees. There are different ways of approaching surgery. There's a way of going between the ribs to get to the front of the spine to do surgery. The literature suggests that that is a bad idea for people with Prader-Willi syndrome, that they get pneumonias, they get infections in the chest. And so by and large, I think that the techniques we have these days, it's just better to stay out of the chest if possible. So here's a 15-year-old girl with a good-sized scoliosis and also a good-sized kyphosis that you see here. And this is what the fusion looks like. So it's screws pretty much at every vertebrae on both sides and then a rod going down on both sides. Here's a young man whose biggest problem is really his kyphosis. And so that's what he looks like after surgery. And that's what his x-rays look like after surgery. Preoperatively, they need a lot of workup. We need to have them go see their pulmonologist. Sometimes they'll need to get a repeat on their sleep studies to see if they're having problems with apnea and to decide if they need CPAP or BiPAP after surgery. And in fact, where I used to be, I had a wonderful person in our intensive care unit who was a pediatric pulmonologist, and he would insist that if the local pulmonologist felt that the child needed CPAP or BiPAP, that they had a number of weeks that they got used to it before they had their surgery, so that we weren't trying to do something new to them in the post-surgical period where you could have problems with that. Sometimes they need to see ear, nose, and throat, see if they need to get their adenoids or tonsils taken out. Anesthesia needs to see them to understand how hard it's going to be to get the airway tube in them, how hard it's going to be to get IV access, to get access into their veins. And very often what I petition for in these children is getting something called a central line. So, you have your typical little IV in the hand that you see and everybody goes to the hospital. That's only good for about 3 days. Problem is that children with Prader-Willi syndrome have a gut that is really slow to wake up after surgery. And for that reason, I oftentimes want them to get an IV that can stay in a lot longer, and that's actually a central vein. So it's either something underneath the clavicle here, or you can put something up inside the elbow here. It's a line in a bigger vein that can stay in for a lot longer, and that way we don't have to worry about if one line falls out, trying to get another IV line in a child that's already hard to get a line in. The day of surgery, we want to be careful that they're not sneaking any food. While they're in the hospital, we want to make sure that the rules are very rigid about what food they're going to get, who gets to say they get food. So in my hospital, the rule always was, I am the bad guy. So any decision on food comes from me. The answer is always no until it's yes. There's never a maybe tomorrow. It's no, 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 yes. Or else you end up having a lot of emotional outbursts with that. And the thing about I make all the decisions, that's not necessarily true. But if the child just fixated on me, they're not trying to pit people against each other, trying to get somebody who might crack under the pressure. Airway management. Sometimes these children are very slow to wake up, and there have been issues with that when somebody tries to take the breathing tube after surgery out too soon. So on occasion, we would just leave that breathing tube in when they went up to the intensive care unit and wait until they woke up well enough on themselves that we could then take that out. So there's no rush to take that out. Other factors, skin picking, we've talked about that. There's a number of different things that I do for that. We can talk about that if you'd like to. But very important that from the moment that surgery is over, that there are things put in place to stop the child from attacking their incision and getting, because it seems like a minor thing at first, but then it turns into a much more global infection. They may have to go back to the operating room. GI complications, the stomach wakes up slower in these children. And so therefore their diet needs to be managed much differently than a typical child. So typically we'll allow them a certain amount of clear liquids to drink right after surgery and gradually increase that as we're hearing more stomach noises. And then we get x-rays to see what's happening. If there's a big air bubble in the stomach somewhere, we know that we're going too fast. We have to slow down. I actually had my worst case was a child who was in the hospital for a full month after surgery. From the surgical standpoint, he could have been out in the usual week or so. But what happened is that every time we thought we were getting close to allowing him to eat more, he would eat, he would bloat up, everything would shut down, we'd have to start all over again. So it can be a very serious issue. And then the last thing that I think is very important, this is probably the greatest cause of late complications, is the alignment from the side, the sagittal alignment that we talked about before. So typically, when you and I are standing, if we drop a line, what we call a plumb line, from the bottom of our neck, it's going to go just in front of the vertebrae, the small of our back, and then down to our pelvis. That's called the plumb line. Now, in Prader-Willi syndrome, what we find is that that line is actually further in front of the sacrum than it is on you and I, and that they tend to like standing with a little bit of the head forward position. And what you find is that well-meaning surgeons say, oh, we can fix this with surgery, and they straighten out the back. And then with the child with Prader-Willi says, no, I like being in this position, and so they will compensate where they can. And then you can have a couple things that happen. One, if this is the back, this is the rods, they can pull away like this. So you get what they call proximal means upper, junctional kyphosis like this, so they're kind of pulling like that. Or you can get the same problem at the bottom where they are leaning forward, and so gradually the rods get pulled away. And this is the main reason for having to come back and redo these surgeries. And so that's, from my standpoint, has become very important to explain to people, no, don't get them corrected to the typical 40 degrees of kyphosis, make it 50 or 60 degrees so that the patient is in a comfortable position, and try to keep the rods not up to the very top of the spine, like we're very often comfortable with, but lower than that, so that there's a little bit of a junctional area where the child can find their own comfortable position for standing. So again, we talked about that, the typical posture, the head forward. And here's an example of that. So actually here, we see how that child is really pulling off forward right over the edge of where the end of the fusion is there. And here's at the other end of the spine. Here's at the bottom of the spine, where you can see right after surgery looked like it was pretty good, but then here the child is starting to tilt forward right over there. And as we keep following that, it becomes more and more of an issue. And they start developing back pain. Here's a child that was sent to me, 17 years old. They had surgery done. And you see this terrible curve. So we actually had to take that surgery much higher up in her back to try to get her in a good position, just so that she could look up forward, because she was stuck looking down at the ground. So a quick word about growth hormone and scoliosis. There's a concern that growth hormone can jumpstart a scoliosis or can worsen a scoliosis. And this is actually something that came out of a completely different condition called Turner syndrome. Turner syndrome, the kids are also treated with growth hormone, and there was concern that growth hormone worsened their scoliosis. It turns out that actually literature now says that that's probably not the case, but this unfortunately then carried over to the Prader-Willi world, where people said, oh, your child's got scoliosis, stop the growth hormone. We've done a number of different studies trying to look from different ways on this. We've written a number of expert opinions on this. And we all feel that the growth hormone has many more benefits than it does have drawbacks, particularly in the area of scoliosis. And even if you have a child with scoliosis, even if the growth hormone fed into the scoliosis, we still think the growth hormone is very important for the rest of the development of the child. But to add some evidence behind continuing on the growth hormone, that 2007 PWS study that was done, one of the things that we could pull out of that was that for every month delay in starting growth hormone, the risk of needing spine surgery went up by 0.7%. There's not a whole lot, but if you then add up all those months together, it starts amounting to a significant percentage. So that was an important piece of the study that we had. So my feeling is that the scoliosis is going to progress regardless. Growth hormone may make them grow faster. So maybe you might see a progression because of the growth, because scoliosis is a growth-related problem. But the overall progression is probably going to be the same whether or not you're on growth hormone. And again, growth hormone has so many benefits that I think it's really important to keep them on that. So with that, I'm going to turn over the microphone to Dr. Wagner, and she's got some exciting stuff to talk about.
Hey everyone, I'm Miranda Johnson. I'm mom to Lucas, who's 4. We've also been with Sam. We casted and braced and ivory. You can make it through the cast, I promise. Hopefully you don't have to get there, but it's doable. So I am here to introduce Nora, Dr. Wagner. She received her postdoctorate in physical therapy from Rosalind Franklin University of Medicine and Science in 2012. Dr. Wagner is an APTA board certified pediatrics clinical specialist and holds advanced training and certifications, including her certified strength and conditioning specialty from NSCA and her certification in the International Scoliosis Therapy Training Program. Nora currently works in school settings, which is how we know her. She actually was with us as PT, and maintains a private practice in the Chicagoland area. Her approach is therapeutic treatment involves breathing and multi-system integration as it pertains to developmental delay, complex medical, and orthopedic impairments. She has a special interest in neuromuscular and idiopathic scoliosis, as well as chest wall deformities. Nora enjoys collaborating with families and interdisciplinary teams to implement carryover of therapeutic approaches within the patient's environment to obtain the best possible outcomes. She's been a great resource for us, and I know she will for you.
But thank you for having me out here. My goal is to not go on too many tangents, but I do love this subject. So what we're going to follow up with now is talking about treating the orthopedic impairments in a more conservative manner. So I am a physical therapist. And so I always say that PTs are kind of like the MacGyvers. If you give us a few tools, we're limited in with what we can do. We can't do surgery. We can't do all this stuff. So we have to figure out a way to work around it. So I have to brag about my profession there for a second. So basically, today I thought when thinking about, especially in Prader-Willi, and my goal was to help you all understand, not only the implications of scoliosis, but actually the physiology behind it and the physiology that's unique to patients with Prader-Willi, and describe how that these physiological processes contribute to some of the orthopedic impairments that we commonly see, and gain a general understanding of the anatomy, right? So you guys won't be doctorates of anatomy when you leave here, but just the basic foundation so that you can kind of start to see how do these orthopedic impairments start to manifest, and then what can we do conservatively to manage that. And then what we'll do is go into the role of breathing as it relates to postural control, which speaks to more of the activity and participation, as well as managing these orthopedic impairments. And then we'll summarize just general positioning, strengthening, and other therapeutic options that are out there to address all of these ortho impairments. Okay, so when I start to think about patients with Prader-Willi, some unique features definitely jump out to me. So obviously, largely, we're going to be talking about musculoskeletal, right? But I can't tell a patient with Prader-Willi to leave their other systems at the door because I'm only treating the musculoskeletal system. So anytime I'm working with these patients, from a PT standpoint, this is what I have to think about in terms of how I deliver my treatment. So musculoskeletal, which is what we're going to talk about largely in this presentation, we know that muscular weakness, the hypotonia, is our biggest obstacle to overcome. And in terms of balance reactions and things like that, I have to be thinking that these patients are more at risk for fractures. So PTs are the ones that get them up and moving and playing. So we always have to keep that in the back of our minds. And then the common orthopedic impairments that we'll see that we touched on just last lecture here. But cardiopulmonary, right? So I'm going to be talking about breathing and postural control, but cardiopulmonary wise, I have to keep in mind that sleep disturbances are common, and hopefully by the end of this, you'll start to see why that is common, and can contribute to sleep disturbance. So if these patients are more fatigued, I have to think about that in terms of how I grade their exercise, what I'm asking them to do, so that we don't get shut down. We actually get productive, meaningful work. And then neurologically, right, we know that delayed motor planning, that it may take longer to execute motor movements, right? There's just an increased processing time. I like to say sometimes it's like there's too many tabs open and you see the processor just stop, right? So once you start closing some of those tabs, you can really hone in on the movement you're going after. And then integumentary, so, you know, this lecture is mostly geared for 0 to 6 years of age, but, you know, I have to think long-term as a PT, right? Pressure points are a big part of our skin, and that's a risk if our mobility is impaired later on when we're kind of heavy enough to generate them. And then something I didn't note in this is anytime we might have any sort of surgical intervention, maybe not necessarily scoliosis surgery, but if there's a requirement for G-tube fed because the child had difficulty feeding very young, some of those, when the G-tube comes out, the skin can actually scar down. And just like you and I, if we had to have a surgery, we've already had the opportunity for our skin to fully develop and stretch. So sometimes if there's surgical scarring, I just like to keep my eye out on that because that can also contribute to some restrictions that can feed more into the musculoskeletal system. So the goal is to link breathing and postural control, especially for these patients. And so the best way that when we talk about the physiology and the basic principles of this, I have to reference Dr. Mary Masry's work, she's a PT herself, and she's actually a pioneer in this study. So she pioneered this whole concept. And the best way that the model seeks is to illustrate the relationship between breathing and postural control using a soda pop can. And I love that she called it the soda pop can because she's so mindful. Just like her, I'm from the Midwest, I'm from the Chicagoland area. So I say pop, but others don't. They say soda. So, I mean, you can already speak to her genius, right? That she thought ahead and just combined the two into soda pop can. And so we think about the soda pop can as it relates to like the human trunk. The aluminum is very thin and flimsy. It's actually not a strong material, right? And so when it's unopened, it's functionally very strong. You can't really crush it unless you were to puncture it with something. And so when it is open, it loses its strength. Why? Because it lost all the pressure inside. When that pop can is closed, the pressure inside is greater than the forces on the outside acting on it, right? So it's able to withstand that, be functionally strong, despite structurally being very weak. Okay, so we have to keep that in mind when we think about our own trunk. The skeleton itself, and I mean, even in Prader-Willi, we have osteopenia. So we already know that the skeleton isn't that strong, but in general, the skeleton is not that strong. It's functionally strong because the muscles surrounding it and the internal mechanisms, which we'll get to talk about in a second, make it functionally strong. And so if you think about a soda pop can as it relates to the human, the trunk here, let me see if I can pull up the cursor. I don't want to lose it. There we go. Okay. So we think about it, it's just essentially the human trunk is just two chambers, and in the middle you see the diaphragm, right? So right here is the diaphragm. So we have a top of the pop can in ourselves, and we have the bottom of the pop can. And so if we have the upper portion, which is what we call the thoracic cavity, and I've listed the muscles that mainly concerns, but it mainly comprises the chest and the rib cage, right? So skeletally, this is what we're talking about when we look at scoliosis and those orthopedic impairments. It's regulated by a valve at the top, called our vocal folds. So I promise I'm not a speech path, but I work closely with them, and I can't get away with working on postural control without addressing the vocal folds. They're very important in kind of regulating the pressure at the top. And on the bottom, we have the abdominal cavity. So everything that comprises of in terms of the core muscles. And then internally is a large, the bulk of it is the GI system, right? So your stomach, your intestines, all that stuff. So respectively, at the bottom, we have the pelvic floor, which kind of acts as a valve to regulate that pressure. So we need all of these to work in sync to get a nice functionally strong unit so we can withstand the forces of gravity that's put on us all day, so that we aren't collapsing and giving it what it wants. So then if we look further, we talk about the diaphragm, right? It's the major pressure regulator. And that's something that's extremely important. So It also has a role in balance and GI motility, and we're going to talk about that in the next slide, right? But it has to regulate the ever-changing pressures between the thoracic cavity and the abdominal cavity, right? So that we can maintain a functionally strong unit. About that. All right, so right here we have, I hope that's large enough to see for you guys. So now we're starting to compare, right? We're starting to take this diagram of the pot pan and the respective parts of the human trunk and actually apply it to the human trunk. So right here in the middle, we have the diaphragm. And so every time that we take a deep breath in, so this is the end of inspiration, you can see that arrows coming down, and that represents that at the end or the beginning to the end of inhalation, that when we take a deep breath, our diaphragm kind of descends, right? It goes down into the abdominal cavity. And then what is really important to note is as that diaphragm comes down, what happens here? What is this arrow doing? It represents the chest expanding, right? So when we all take a deep breath, we don't take a deep breath, our diaphragm falls to the floor and then our chest caves. That would be really inefficient, okay? And again, that would make us start to lose some of our functional strength. And so the chest has to counteract. And how it does that is with the muscles in between the rib and then the upper muscles here involved in respiration to counteract those forces. And so when we talk about at the end of an exhale, the diaphragm goes back up and the chest returns to normal resting position. So the two have to work in sync in order for that unit to stay nice and strong and combat the forces of gravity. All right, so you can really tell I'm trying to drive this principle home. It's really important. So this is what the product is. When we have adequate pressure between the two cavities and we have something regulating it internally, as well as syncing with the muscles outside of the trunk to regulate the pressure so it doesn't come out and cause us to collapse, we have a nice intact pop can, right? Well, what happens when we open that? When we open the top of that pop can and the pressure comes out, right? So now the pressure inside where we were functionally strong, the pressure inside was greater than the forces acting on us. When we open that pop can, we lose pressure. So meaning one of those cavities, the intrathoracic or the intra-abdominal cavity, has had a compromise in pressure, or maybe our diaphragm isn't efficiently regulating those pressures. You could see how the pressure inside, if we've lost it, is now not greater than what's acting on us. And so you can see how that will cause some collapse. And so you can already see where I'm going with this when we talk about scoliosis, right? We see very similar, right, bending in certain ways. And that speaks relatively a large amount to what's going on in the inside in terms of how these pressures are being managed. All right, so why is that important? Well, now you guys can see why that's important just for everybody. But how about Prader-Willi, right? Why is this really important in Prader-Willi? Okay. So when Dr. Van Bosse was speaking about how distally kids with Prader-Willi are stronger and centrally they're quite weak, okay? We know that the compromise, there's already compromise going on within those pressure systems. And so if we can actually account for those, correct those, using musculoskeletal techniques, using breathing techniques, right? We can create a strong foundation. So centrally we can become strong, and distally we can apply that. And that just means better movement efficiency, right? We say that activity levels for Prader-Willi are so important. They need to stay active, not only for the health implications, right? But just to manage also those orthopedic impairments. We know just the multiple realms that activity plays in our lives, whether it just be for health, whether it be socially, right? So this is where, as a PT, I start going into why do we need to start here so that we can actually functionally have a good quality of life. So if we make movement efficiency easier, we get less tired. If we get less tired, we can do more, right? So it becomes a very positive feedback loop. We talk about head control, okay? If I have in the Prader-Willi population that kyphotic posturing, if you all don't have neck or back or any issues, I welcome you to give yourself a kyphosis by taking your hand, pushing your chest in, rounding those shoulders and craning your neck, and tell me how comfortable that's going to be for the rest of this lecture, right? Let alone, I'm not asking you to talk, I'm not asking you to play, I'm just asking you to sit there. It's not going to be comfortable. So we see head control. I mean, it makes all the sense in the world that feeding is going to be difficult, right? So if we don't have a good alignment, a lot of other things can become impaired. When we talk about head and trunk control, we talk about balance. You know, we need to come up with balanced reactions. We need to see our environment and respond to the dynamic activities going on around us. So if we don't have good head and trunk control, our fall risk goes up. And so, you know, these patients are more prone to fractures. So that's something that we want to eliminate altogether if we can. And in the next slide, or the next column up here, it's a little fancy word of saying proximal pressure to produce distal limb force. So actually, when we can adequately maintain these two pressure systems, right, we can actually take the pressure that we're now centrally generating and apply it to our limbs. So we can use muscular force, which we know we need to strengthen bones. Okay, it's the Wolff's Law. We just need to, the bones will adapt to the stresses that are applied to it. So if we can actually generate more force from the correct place, you can see how that becomes a very positive feedback loop for bone strengthening, besides all like the medication, the vitamin D, and all that fun stuff. And then airway clearance. This is something I promise not to go out too many tangents about, but airway clearance is just so vital, again, because these kids, when they get sick for longer, they get sick more severely, right? So if you think about, we don't have enough trunk control to generate or tolerate those high pressure moments, such as coughing or valsalvating for the bathroom and things like that. Well, if we can't clear those secretions out of our lungs, they're going to stay there a lot longer, right? And so that's just not fun for anybody, especially a parent taking care of a sick child. And then what we're going to get into here, the bulk of this topic is, again, preventing those postural deficits. So just to understand, right, we went over understanding the basic principles of breathing as it relates to postural control. So we need to understand how the chest wall develops in early infancy so that we can set up a good foundation later on, so we can eventually sit, we can eventually stand, we can eventually tolerate all those forces being applied down on our spine through gravity. So if you look at a newborn child, their rib cage is actually oriented a little bit differently. Their ribs are extremely close together. I have a picture of this in the next slide, you'll be able to see. Their ribs are pretty close together and they're relatively horizontal, so they're almost parallel with the floor if you put them up against gravity. And then through a process of development, what happens is, as we use more of our soda pop can trunk muscles, right, to help separate those ribs, now resembling more of that mature formation on our way to approaching a skeletal maturity, you'll see that the ribs actually come down. There's a lot more space in between them, and they're no longer horizontal. They're more of an oblique sling that comes down and kind of wraps around that chest wall. So this is just to illustrate that. Keep this in mind because we're going to compare it to what happens when these systems go awry in development. So here we have a typical 1-month-old, and you can see how close that rib space is, right? They're all kind of smushed together. The ribs are relatively parallel and horizontal if you were to put that child up against perpendicular to the floor. And then if you see over 12 months, how much those ribs have dropped into the sling, how much more space we now have for the upper ribs, which are really important, especially in this population, to develop, and the more mature formation, right? So those ribs have really gone from parallel to that nice oblique sling that we see. And so what happens in development if we don't have the adequate muscular control to develop this chest wall, right? So you can see here, this is, I love this girl. She is sassy as all get up. So when I met her, she was 5 going on 6, and this was her presentation. So even before I met her, the report said she's largely non-compliant. She's not motivated by much, maybe one thing. At the time, it was penguins. She didn't participate in class. She was nonverbal. And what was really important for her was she used a adaptive device to speak. So she needs head control so that she can look at that adaptive device and say the words when she communicates with her friends. Okay, so they're saying, you know, she doesn't want to talk, she doesn't want to participate. And I'm kind of reading these reports thinking, man, this girl's getting a really bad rap. She's gonna be a tough sell, right? So I'm kind of nervous meeting her. And when I go to meet her, this is her presentation, and I'm like, well, no wonder, right? You can really see down here, let's look at the foundation, right? Her abdominal tone is so poor that when her diaphragm descends, it just squishes the GI contents out. There's nothing to counteract and hold that popkin. And I don't know, women in here, if you love to wear Spanx, it just gives you that nice support, right? We can all relate to that. So if we don't have that, what happens? We feel like everything's falling out. So here you could see what kind of foundation does that set up for us? If the diaphragm, right, we all talked about just a second ago, if I breathe in and my chest wall falls, that's not really efficient. And thankfully, you know, we're all lucky to benefit from that, but that's not the case for a lot of these kids. So as the diaphragm pulls, right, because right now, what she's trying to do in this position is just survive. She's just trying to breathe and make it. She's got no other time to think about lifting my head, participating, feeding, right, playing. I'm just trying to breathe. So every time she takes a breath, her chest wall was so weak and underdeveloped in early development that it would just collapse. The more and more she got fatigued, the more and more she got fatigued, the faster she had to breathe. The faster she had to breathe, the more her chest kept falling in. So I'm like, of course this girl doesn't want to participate. She's just focusing on breathing for the task at hand. So her in her here, if we look, it's kind of hard to see with the arms blocking a little bit, but that chest wall, really, the rib cage is just folding over the abdomen here. So even in the front of that chest wall, there's just really no muscular support to help her manage even up or above. Right? Look at the space, this foundation, right? You can see why head control is such a problem for her. So when she did want to, these kids have to really be selective with what they want to participate in. The only thing she loved at that time that she would actively lift her head for was penguins. Anything else she wasn't interested in. So I kind of think about this, like if this is what you're working with, you really have to be choosy on the experiences you have, right? So she was set up to, for a whole, oh man, just looking at that. Her resting respiratory rate, by the way, was 44 breaths per minute. So she had all of the breathing in her diaphragm. She had nothing to counteract in the chest. So you can really see how does that set us up for that kyphotic posturing, right? I mean, if we have a weak chest wall, we're just set up for this. And then gravity has a field day with us. So then it becomes a very negative feedback loop. And that is, you know, the large consequence of hypotonia, which we all try to counteract. So this was her when I met her. So she was, again, like 5 going on 6. And you can see just on this side, let me see if I can pull this up. Oh. So we can see that spine all ready to succumb to those forces, right? If you think about back to that newborn that I showed you in development, those ribs are really close together. They're very parallel on one side. On the other side, they're almost overcompensated for, right? So now we're talking about if everyone wants to give themselves a large C curve and bend to the left and take a deep breath, you're going to find it's easier to breathe into this side. Okay, so now from the inside out, we continuously overstretch this way, we continuously shorten, right? And we could really see how this becomes a domino effect. And then gravity just has a field day, gets to win, okay? So now we look at the side profile of her, that's the kyphosis. And then look at that lordosis that has to compensate. So things like sitting, things where we have to just have a stable pelvis, we're already compromised. And that's just the effect. Again, it's really hard to see on this one. These are the ribs. Look how horizontal those are. Again, it resembles more of a newborn chest. So she was 6 and she still had a very underdeveloped chest, just similar to a newborn. So we want to correct that. This is one of my favorite examples to give, because we all experience this in our everyday lives. And any way I can find to relate this to, just in general, it's easier to understand the implications for these kids, right? So this is a picture of Usain Bolt. He actually has scoliosis, which is why I just picked it for that example. But also, what is he doing in these 2 pictures here? Right? He's the fastest runner in the world. So when he races, I mean, he gives it his all. So you think his work of breathing goes up just a little bit, right? So what happens when he finishes that race? If you all have laughed so hard that you had to double over, if you guys have had to ever go catch a train and you're trying to stay upright and talk to your friend on the train, the natural inclination our body wants to do is to double over. Well, why? If we go back to that skeleton picture, the diaphragm moves this way, right? So it has to counter gravity. So what do we do to take some of that measure off so we can focus on breathing? Is eliminate the gravity. So if we go here and bend over, our diaphragm doesn't have to work so hard against gravity, right? And then we can ventilate, catch our breath, and stand back up. So it's just a nice summary of what the research that Paul Hodges does. And he says that if the physiological support of breathing is compromised, the postural response of the trunk muscles will be reduced in order to meet the demands of breathing. So what does that mean in everyday life? You have 2 choices. You can breathe or you can have postural control. The minute you start sacrificing some of that breathing, guess what the body's going to choose? Thankfully, breathing at the expense of postural control. So if the work of breathing is so high, you'll see total gravity elimination just so that diaphragm can move more freely and totally eliminate a lot of the gravitational forces it has to withstand. So this is largely, I mean, if you think about now, this is for when you and I are really pushing the limits, right? This is for when you and I are increasing our demand of work of breathing and we're laughing so hard. Our air hunger goes up. So we double over to meet that, and that way we can keep laughing. Well, with kids who are hypotonic and Prader-Willi, this is their everyday life. Activities that may require their work of breathing to go up, we'll see that presentation more frequently when you have poor muscle weakness or poor muscle tone. And so often you'll see that if one of my favorite examples is when one of my kids before, he would talk to you all day when he was sitting. He would certainly sound even more clear when he was Usain Bolt on the floor, right? Not dropping syllables, clear as a bird, right? Because he had less postural demand. So breathing wise, he could get that nice full breath. He didn't have to counter gravity. And then his words were beautiful. He could string together longer syllables. As soon as we put him up to sitting, it was okay. It was just a little less. The minute I had him standing and walking with me, or if I saw him in the hallway, I'd be like, hey, Johnny, how are you today? There was this. I can't talk to you right now. I'm just working on stabilizing and breathing, right? So we see that even if he wanted to talk and get all this stuff out, his work of breathing was going to go up, right? So he had to make that choice. I can talk to you, but I might fall down, or I might have to lean on something, right? So these are the situations that if you have hypotonia, if you have poor muscular control, you're going to have to be making every day. So sometimes I think it kind of just like my girl in the last picture, it gives you a bad rap. Sometimes you could see like behavior go up or refusal go up. And sometimes we have to think about the demand we're asking on these kids and if they can adequately support it. So again, going back into the, this is needed for speech production, those high pressure movements, such as coughing or sneezing. And then again, the failure of the chest wall, that's largely what it's about. The development, the underdevelopment of the chest wall and the rib cage muscles is what we call that paradoxical breathing. That's just simply, as my belly breathes, my chest falls in. That's largely paradoxical. It's not how it's supposed to go. So you could, and that will just drive more into the kyphosis. So now you can kind of see, right? We have inadequate chest wall development largely in these kids. And you can see how Gravity had their field day. And then when they meet me, they already have a scoliosis. And so we talk about, right, I'm not going to make you guys do mental gymnastics, understanding the three-dimensional components of scoliosis quite a bit. But if I think about it, you know, in what strikes me the most is that in Prader-Willi syndrome, from 0 to 3, it's 30%. I mean, I would still love 0%, but it's better than 80% at 10 to 16-year-olds. So we have to think, well, why is it so significant for 10 to 16-year-olds and largely not there for the 0 to 3? Well, we already know development is delayed. So how much gravity are they really countering at 0 to 3, right? And then we have to think, little people are closer to the ground. They don't have to fight as much gravity as growing kids, right? So as we can see, as the forces demand goes up, the farther away we get from the ground, and that you'll see that should explain why the 80% happens for the teenage population. I thought something else that was interesting in the research was that in Prader-Willi, the long C curve was what showed up more in the younger populations. And so if we kind of think about, again, that breathing inefficiency, so this side is going to be pretty closed down. I'm not going to breathe very well into this side. This side is developed and rounded out. So it's going to be easier to breathe in this way. And then if you put on top of the fact, how many repetitions of breath do we take a day? Right. So I'm going to keep driving into that curve, especially if I'm up against gravity. And then the kyphotic posturing again closes the chest wall. The diaphragm becomes stronger in that position. It's biased towards breathing in that position. So the more the diaphragm pulls, the more the chest falls. In S curve, I just want to note that it's, so this is a patient that I have who has an S curve. It's really important to note that the driving curve, which one's driving this double curve, okay? So typically there's a driver, and then typically there's a compensatory one that has to balance the system out, because you can see this is already 42.5. If this continues to progress and we see the manifestations posturally, eventually what will happen is we'll just keep falling to the right. And so what the body can do at times is compensate or compensate at the bottom, right, to balance out that curve. So in most cases, I do find that there's a driver and one just has to compensate and account for that one. So if we can identify which one's driving the mess, then we're better able to control for it. I always say, right, I'm a PT, I have to say this, right? The best way to fix a deformity is to prevent one, right? So PTs are largely preventative. And so when we see these instances, when I already meet kids with scoliosis, and I didn't get a chance to meet them as a young kid, I'm like, ah, man, we could have avoided this altogether, right? So, but you know, that's just, it's how it is. It doesn't mean that we can't correct for it, but prevention is the easiest way. So if I already am working with a family from a young age, I'm going to just do a lot of education with the parents to look for the signs that something may be developing. And so this girl is a perfect example. You can see how I highlighted. Her shoulders are asymmetrical. Her hips are asymmetrical. This one's higher. She's actually displacing more weight on her right. So her curve ended up being very dominant in the upper thoracic. So it pulled her so much that she was just putting all the weight on her right leg because that curve was driving it, right? If you see the upper limb screen that I do. So instead of just the bending over test, I do that with a scoliometer. If it does come out to 5 degrees and it's hard to see on a kid, anytime that it tells me 5 degrees on a scoliometer, I'm sending them to the doctor for x-rays, because there is good research to support that 5 degrees kind of indicates a 20-degree curve. But other than that, I'm looking at posturally. Look at her left arm. Can't even get it fully straight. Why? Her left side's already succumbing to the force, right? So if you give yourself a left side bend and then tell me how much you want to raise your hand, you can already see I don't have any shoulder impingements. I don't have any shoulder problems. I literally can't get my arm up, and I was, typically developing, right? So when we have to look at postural strain, how are these kids looking when we're asking for end range of those limbs? The other thing I think is kind of interesting is, what is their motor patterns telling you? So if I'm already going to be predisposed to rotate to the right, maybe I'll be fine crossing my midline in my left, but when it comes time to cross the midline of my right, I can't, right? So you'll see kids actually set themselves up, position things that they can maneuver that feeds into the curve, right, instead of against it. Jumping is typically asymmetrical, so one leg is leading and the other one kind of follows. And then there's always a preference for using one leg. So if you're still, working on that reciprocal stair climb, you just can't figure out why it's not happening, sometimes that's where I'll start to look into a postural strain and see if something's going on. And clothing, I love clothing. It's a big help. I really like this example because you can see on her short side how much that shirt is bunched up and kind of pulling into that direction right there. If they're girls, you can usually use like the skirts with the waistline. Usually those will become a little contorted. Or girls when they have the spaghetti straps, right? One's always constantly falling off. It's annoying them. I also use like clothing. So actually I had a patient referred to me because that's how they actually found out. The spaghetti strap kept annoying her. So they went to the doctor and there it was. Okay, so we talked about all that fun stuff. Now, how do we treat this? So in general, I think what's relevant in Prader-Willi, it's often not present. The scoliosis doesn't happen until the child is exposed to upright positioning, right? So until they're put up against gravity, we really don't see it. They're not necessarily born with the scoliosis. It means they acquired it. So we really have to, again, going back to that upper rib cage, the underdeveloped chest wall, we really got to focus on those muscles so that we can separate the ribs. We can use those muscles to create space, to drive the typical development, make sure that all planes are accounted for, and that's fine. And so when we talk about developing the muscles, we want to go, let's see here. Okay, good. It's coming up on the next slide. Stay tuned. This little picture. So when I talk about Prader-Willi, usually in the postural deficits that I see with the chest wall being impaired, it means I want to A, facilitate the chest wall, and B, I also want to activate the abdominals. So why do I want to activate the chest wall and the chest muscles? Because those muscles separate the ones at the top, create space between the ribs, and the abdominals on the bottom hold the bottom of the rib cage down. So create space from the top to kind of cause that nice gravitational downward rotation of the ribs that we want to see. So chest wall and abs, that's largely what we want to address for these kids. And what else? Let's see. Well, we'll go back and forth, I guess, between this. So how do we do that? Well, in a baby, I mean, how are you going to tell a baby to do push-ups, right? Kind of hard. So what we could use is just natural physiological responses. So if you've ever done yoga, or even if you go to raise your hand, if everybody wants to raise their hand, I'm a PT, my goal is to get people to move, right? So if you go ahead and raise your hands, and then put them back down. Now raise them again and notice if you take a deep breath in or out, what happens? Should be in. Everyone should have naturally gone in, right? So why does that happen? As soon as the arms go above 90 degrees, We drop something called pleural pressure in our lungs. That causes a natural inhalation moment. So I don't have to tell a baby to take a deep breath. I can just start to work on getting arms past 90 degrees to cause that nice inhalation moment in the chest. What else happened when you raised your arms? Oops. Did you go into that upper back extension or flexion, right? Everyone went into extension. What do we want to counter with these kids? We want to counter the flexion that we see, right? So arm and shoulder maneuvering is extremely important with these kids. I also say it's to their advantage because they're usually hyperlax, right? So it's quite easy for these kids to be in this position. Win-win for us. Tummy time, right? Kind of like waiting for anyone to throw a cup at me when I say tummy time, because I know how hard it can be to work with those kids who don't enjoy tummy time. But if you think about tummy time, right, it's a new perspective on tummy time. Not only is it good for strengthening those back extensors, we need those, right? But what else does it do? It activates the chest wall so that those ribs can start to separate and drop. So tummy time is not only good for the back, it's good for the chest wall. I'll show you some modifications on how to accomplish that, right? And then we start to promote like more of that closed chain pattern. So we start to, again, tell the body we start here and then we move. We don't move here and then activate this. Abdominal facilitation. So using muscles of the anterior core, the obliques, the abs. Usually I like positioning. I'll show you some examples of it. But the more we can use positioning to our advantage to recruit those abs, the more that they're pulling downwards on the front of those ribs, creating space for the whole thing, and for more of that mature skeletal formation. I do like abdominal binders to assist with this. Again, it kind of goes back to that Sphinx principle. Gives you some nice support. It helps to shape the ribs a little bit. But I do caution if the baby does struggle with GI symptoms like reflux, don't use the abdominal binder because as soon as the baby would see me come in and put that abdominal binder, they're going to associate me with someone who's awful, and then I'm never going to win them back. So I say reflux is my deal breaker. Don't use an abdominal binder if the baby has a significant reflux. So these are the modifications I like to use, especially for that tummy time, the chest wall development, right? So if you could see on this one, this is actually my niece and nephew, by the way. They're excellent models. So you can see my hand. What is my hand doing? It's kind of compressing in at the abdomen, right? So I'm acting as the pressure regulator that the abdominals do. So I'm holding in that as she breathes and uses her diaphragm, she can actually not continuously be losing that pressure where her belly's falling out, right? So I'll start her upright where it's a little bit easier. I get approximated on her lower rib cage and her belly. And then what I do is see what range can she maintain that head control. And so my goal is to eventually get her from upright to horizontal, but I work with where she's at, right? So you kind of have to scale it in terms of that. And I like to use mirrors for this or any light up toys that they might be engaged in. You can also, right, so you see here, what am I doing with my hands? I'm holding those elbows right under the shoulders, right? So if you kind of leave kids up to their own on tummy time, often what you'll see is kind of this, and then lifting the head becomes very hard. And then the breakdown happens, and then the head goes in, and it never comes back up until you lift them up because they're crying, right? So if you could give them that support, just hold those forearms, hold those elbows in place under the shoulder, I'm still getting chest wall activation. If you see I'm doing it on an incline, why is that? Who's ever tried to do a push-up on their toes versus on their knees? What's easier? On your knees, right? So if I can offset some of the upper body weight onto my legs, I can make my arms more available for work, right? It's the same principle. And so you can see too, if this isn't a good option, you can incline them on that way. You can still see that I'm holding her elbows in place. And I'll do this for as long as they'll let me, right? So ideally I'd want to, start with 15 minutes or so after 2 months and work my way up. But as long as they'll let me do this, I'm going to do it. As they kind of mature, right, get a little bit bigger, you can actually put a towel roll under their arms for that support. So it kind of works in that same way of weight displacement and kind of shifting things around to make, now we're moving from our forearms to our hands. So look at that nice straight force there. And the hips are actually getting some load too. So hip dysplasia, really good for the hips. I do like sideline play. It facilitates, rolling, but also inside lying, I kind of let gravity just take the side that's down on the ground and help shape it a little bit. And I think that all of this, you can see here, the incline right on 30 degrees of the head, and there's just a little towel roll right under her low back, and that makes it easier to recruit the abdominals. And I can do little kicking games. I usually say to do that at diaper changing times, because how many times do you have to do that throughout the day? It's a good way to get in repetition. And you can see I never go away from this. She's 6, I'm still making her do this. Vertical play. Love vertical play. So here you'll see we're progressing, right? We're getting older. We're getting more interested in other things. How can we take advantage of that and still use gravity? So now how can we train these postural muscles to counteract gravity? And a large way to do that is vertical play. So you see this bothers a lot of people. They want to move that scooter, right? To make it easier for the kid to get to the target. I want them away from the wall. Why? Because now they're leaning. They're putting weight through that arm. They're still working their chest wall, even though they're playing. So sometimes I'm tricky like that, right? And then what are they doing on the other hand? Reaching, opening that space. They're still using their chest wall because they got to paint and pull down. So vertical play, you can actually get quite a bit done. I like to, anytime that I have, we're getting into chore age, I'm going to have the parents give pushing chores. So you're going to push heavy laundry baskets. You're going to push heavy door open, at school. Their job is going to be the door opener. They got to hold it while the whole line passes. That's their job every day. Little vacuums. That's a nice way to do it. And positioning, even if you make it past 6 years old with me, I'm still going to be focusing on positioning. It's so crucial. And it just makes everyone's lives easier. So you can see here, my nephew right there. Here he is just sitting, pretty standard on the mat. But look at what his spine's doing, right? If we're trying to avoid kyphosis, man, we're kind of giving it an opportunity right there. Look at how much he has to crane through his neck to look up at me. So what I did is just took that mat, put a little pillow from a couch right under the mat. I put it on an incline so that the hips are just slightly above the knees. And look at how that just fixed everything, right? He was able to play a lot longer in this position. Back to the babies on the incline. I don't even get away with it with my toddler or growing kids either, right? I can still use inclines to help me recruit those abdominal muscles. I can still position the legs at 90-90 to help recruit those abdominal muscles. And here now we're working in a really nice sagittal plane where he's got to get something heavy and give it to me, right? So we're just starting to add a little bit of load for those older kids. And then addressing rotation, right? You can see my hand, my emphasis is on keeping that elbow straight. I don't want collapse because that means that I'm not applying the forces correctly. So sometimes you need to assist there. And then my favorite thing, these are boring principles carried out in 1,000 different ways. So you can constantly change the environment and still keep the core activity at hand, right? So this girl, if I want her reaching on one side to lengthen the shortened side, I'm going to give her balloon toss, right? So she's got it, it becomes a game. The parents here, they actually had a cool wall that they painted in chalk after, we were talking about vertical play. So not only are we doing lots of chalk drawing, you can even go to the dollar store, get the really bad chalk where they got to press really hard, right? I like the dollar store. Same thing with the Play-Doh, right? It's bad material, but it makes more work for them, which is perfect. So, get the really bad chalk, make them work, draw all sorts of things, but also you got to clean up, right? So you got to get the sponge, you got to wipe it down. You still got to use that chest. I'm still elevating. I'm still fighting that kyphosis, and getting the thoracic extension that I want. So you could do it a million different ways, and these can all be done in the brace, right? So if your kiddo's wearing a TLSO, you can obviously do it that way. All of these can be done in that. Stamps, love stamps, a lot of pushing. And so here's after 6 months working with my patient. I mean, you can see the difference, right? So we went after that chest wall development, and we went from not being able to dependent or independently sit to independently sitting with good head control, right? Nice breathing mechanics, really relaxed posturing, right? So you can imagine how much this opened up for school day. Like now I can engage with my peers. Now I can see what's going on. She did use a stander for most of the day, but you can see I can communicate on my communication device. I can look up, can use my eyes to use my device to talk, right? And I don't have to work so hard. This is her, you know, she's so excited for the first day of school. But a year later, again, we're getting more midline, where she's weight bearing excessively on this leg. Now she's pretty even, right? So we could really see how we could use this whole idea of breathing and postural control to get some pretty good results. And here she is just using her her device, which, by the way, her favorite thing to say was no, and this is boring. So this is her after that intervention, 6 months of intervention. The last picture on all the way on the right is after a year. So you can see again that spine came way more midline. We were able to get a little bit more separation on the ribs on the tight side. These compressed nicely, and I actually wanted a shortening on this side, right? And so so that was really cool to see. But most importantly, just the kyphosis. This is what she had to struggle with so much to engage in her everyday life. And you can really see just after about a year, these are a year apart. So that's a pretty cool results. This is my nephew. You can see he did have the Pavlik harness for hip dysplasia, but you can see just that posturing that's very atypical for babies. And by 4.5 months of intervention, he was able to find midline, use his abs to play with his feet, and all those cute things that we love kids when they do, and do that adorable little chin tuck. Right? Why are double chins so cute when you're babies and then they don't get cute anymore? I'm like, so unfair. And then this is a 4-year-old boy with Prader-Willi. So he started at about approximately like a 30-degree curve, and then I think he's around about 13 or so now. So pretty cool stuff that can happen. I already talked about these largely. These are usually the external supports that I use. So I mean, I love doing therapy without the brace, but when fatigue sets in, when I'm not around, I rely on the external supports to keep them upright and, keep gravity at bay. And then this is just some general information on Schroth. It is a unique approach to scoliosis. It uses, again, like that angular breathing. Breathing is a large component of it. It uses more of the sensory motor. So how I was showing you the different apparatus and ways to stimulate these kids to do activities, it kind of incorporates. What I really love about it is the positioning. They really come up with the Schroth technique came up with just a brilliant way to position these kids throughout their day to even make gravity even less demanding on their system. So it's usually developed delivered in 12-week bursts. So about you do about 12 weeks at a time. You do the home exercise program. You usually come back about a year for another tune-up. It's really well supported in the literature right now for idiopathic scoliosis, but right now the only strongest level of evidence we have for neuromuscular for the very young kids is mostly case reports. So we do need more research to see if it is effective with these kids, but I use it all the time for positioning. And the Schroth technique largely incorporates that bracing with the Schroth principle. So, so this is kind of like an example where if this girl, her curve was this way, so all we have to do, if this is the short side, is flip her around, or sorry, this way. This is her before. There she is. There's the curve, right? So if we're feeding into that curve because it's more comfortable that way, we just flip the legs around, and now you can see we kind of open up that trunk, and our head's a lot more midline. We can give corrected posture. So these are like little bean bags or towel rolls on their seating apparatus. And then we encourage what we call active posture. So we train, like if you're standing in a long line, you're going to do your active posture. right? That's where you're actively working to maintain midline. And then just a few other points that, you know, if range of motion and things, restrictions, if the scoliosis has already developed and that range of motion is really difficult, I do like aquatic therapy. It's a nice way to eliminate that gravity demand again. Usually it's delivered in like a warm water temperature that kind of helps to relax those tight muscles so that you can kind of open up and work on that range. But I do say that because of the bone softening that comes with Prader-Willi, that it's important to, if you're going to do aquatic, to at least complement it with one session of dry land where you are working on that bone strengthening, because they do need the gravity to get stronger. And then hippotherapy, which I already know is very well known in the PWS community. But what I really love about it, if for providers, right, is I love that you can effectively co-treat. So every time I've been to a hippotherapy place, that's what I love, that OTs can work on OT, PT can work on PT. You know, you're really, really getting effective care in a short duration. The kid doesn't feel pulled in a million different directions. So I really like the opportunity for that, the interdisciplinary management. So just to sum it up, we can see how, you know, the detriment effects of that hypotonia and that muscle weakness, how it not only, you know, affects their participation, but it affects their skeletal alignment, right? And so we know, you can see how that negative feedback loop can happen in kids with Prader-Willi. But however, when we take into account that breathing, we take into account how it is related to postural control, we can really harness that to kind of spin that back into a positive feedback mechanism and get really good outcomes for these kids. So but it also just kind of helps, right, when we incorporate the breathing and posture control, how it's not just musculoskeletal, it kind of feeds into all of the multi-system impairments that these kids may face to improve like their quality of life. And then from there, I got my little nephew working on his range of motion, fighting his kyphosis. I thought that would be a good time for a question slide.
Probably want to use this room. What if I have, you maybe give us a couple of minutes, I got a couple of minutes about everybody else does, and then we maybe meet inside room for 2 weeks and then outside a little bit.
That's great. Well, thank you both again for that. That was really interesting. We've lived through some of that, but there's always so much new information to learn. So thank you both again for that. Also, just lastly, wanted to thank our presenting sponsors, so Selena Therapeutics, as well as all of our sponsors, Harmony, Radius, Aardvark, Novo, Latham Centers, Constance Therapeutics, Nexus, Neuron Pharmaceuticals, and Gideon Richter.